طيب، بسم الله الرحمن الرحيم. ومواصلة في السيريس بتاعت الليكتشرز الموجهة للترينيز في السودان. معنا الليلة الدكتور لؤي بلال. دكتور لؤي يعني من أوائل الدكاترة السودانيين الموجودين في أمريكا. احنا كلنا جزء بسيط، يعني عددنا كلنا افتكر 13 14، لكن من أوائل الدكاترة الموجودين هنا دكتور لؤي. هو افتكر عمل تريننج هنا في أمريكا، يعني افتكر حوالي 2007 2008 في فيلادلفيا، في توماس جيفرسون. افتكر هنا ميديكال، لا، في توماس جيفرسون هوسبيتال. وبعدين اتمشى هي جويند افتكر يونيفرسيتي اوف كاليفورنيا. وبعدين هسه هو شغال هيز ان انبيشنت دايركتور working في الكونسلت في كايزر بيرمننتي. يعني he has had that job now for a couple of years، وعنده خبرة كبيرة في الانبيشنت سايكاتري، الاي سي تي، الكونسلت ليجن. فدكتور لؤي تفضل.
شكرا جزيلا يا ياسر for the kind invitation. يعني مبسوط جدا جدا ألاقيكم كلكم، وإن شاء الله تكون محاضرة مفيدة. هي محاضرة خفيفة، وكلها يعني about clinical care. It's highly clinical، والفوكس بتاعها من الهوسبيتال سيتنج. في حاجات الزول ممكن يتعلمها من الهوسبيتال سيتنج. وبعدين trying to stay honest to my experience. I'm an inpatient psychiatrist, and that's the bulk of my experience. So I named the talk Inpatient Psychiatry, Teachable Moments from the Trenches. برضو بستهل الكلام برضو بدعاء، يعني إنه ربنا يزيل الكرب ويوقف الحرب، ويرجع السلام والأمان لبلدنا السودان إن شاء الله. وإنه السنين اللي فاتت دي غير الحروب كان في مشاكل كثيرة في الدنيا من بانديميك وغيره، فالبريفالنس بتاع المنتل إلنس فعلا زايد. فربنا يعين الجميع إن شاء الله، ويحقق الأمان بإيقاف الحرب ويسود السلام إن شاء الله. أنا ما عندي أي financial conflicts، ما عملت patents ولا research على اي contribution مع شركات ولا كده. ما في زول بيدفع عليه غير الامبلوير بتاعي. والاكسبيرينس بتاعتي في الاكيوت كير سايكايتري وفي الادمنستريشن. فانا برضه I'm thinking as an administrator وانا بقدم اللكشر دي. الاوبجيكتيف انه talk about guideposts من الكلينيكال encounter. يعني when you meet the patient there are guideposts when you focus on it can help you in rendering quality patient care. Throughout the talk, I'll make suggestions for relevant resource material for discussion, case-based learning, or further study. For inpatient care, an overarching goal هو timely diagnosis and treatment. لأنه inpatient beds are a scarce resource في أي بلد في الدنيا. دائما بتلقى انه number of inpatient beds is pretty low. Getting faster to diagnosis and implementing a treatment plan early as possible is a goal for most inpatient places or units. برضو the second overarching goal انه you want low complication rate. You don't want to cause harm, or you don't want to cause adverse events or complications from your treatment. And the last objective is, as much as possible, you want the patient to transition out to either home or to any outpatient alternative where they can continue their care. These are the guideposts from the clinical encounter. That means you can think about it this way. If a colleague asks you to look at a case or to help out, what are you going to be looking at? So someone is presenting a case for you, you'll be thinking first about the diagnosis itself. What is the diagnosis? Did we get the diagnosis correct? The second is treatment selection. Once you start the treatment, you commit to it and it has its set of side effects. Is this an issue of treatment selection? The third guidepost is what happens when you have a case where there is non-progression in treatment. There is only partial response, or there is very slow response, or there is no response. What happens? And then the fourth guidepost is treatment resistance. Are you dealing with a case where this is a resistant condition? And that's important because treatment resistant states have different evidence-based guidelines for how you treat them. You may get a case where you did not identify this as a treatment-resistant condition, and so you ventured out treating with inappropriate treatments or treatments that don't work for treatment-resistant states. And the last guidepost is prognosis. Do you understand the prognosis of the case that you are seeing? So the issue may not be about the diagnosis. It may not be about what treatments you selected. It might be about the prognosis. So for the rest of this talk, these 5 guideposts are really important to just keep in mind and to take them. They're very portable. They're sort of things that you can immediately think about when someone consults you in a case. And we'll go over each of them in turn. Okay, diagnosis is the first one. This is, I guess, a highly sort of American bias. We think a lot about the DSM-5. There might be ICD-10 or other diagnostic systems, but the basic idea is that you're using one standard. So if you're training in the US, or if you are training in places where they preferentially use American system, then the DSM-5 would be the undisputed standard for the diagnosis. And that's okay. ICD-10 is very similar, but the DSM-5 is sort of the standard. The structured psychiatric interview using DSM-5 criteria allows for accurate target symptom definition. So what that means is that you have essentially a checklist of questions that you ask that are based on the DSM-5 criteria for each of the common psychiatric disorders. So it's good to use those. The second item is the biopsychosocial treatment plan, and we'll go over that. This is important. There has been some little bit of a dispute over the utility of the biopsychosocial formulation. So this is not talking about the biopsychosocial formulation. This is talking about the biopsychosocial etiologic factors. And so we'll spend some time talking about that. Related to the structured interviews, response measurement, that you really define your target symptoms, and then you have a way of actually measuring the response. And all this flows from the diagnostic interview. It really flows from you sitting down with the patient, going through the DSM-5 criteria and arriving at a diagnosis. So the diagnostic interview, or the initial intake that you do with the patient, has the most bang for your buck, essentially. It's really the main thing that you have to focus on. It's an extremely high yield event with the patient. The third item in the diagnosis is you have to really be awareness of the illness prevalence. So this is something you've heard a lot in medical school, that common conditions occur commonly. So this means that if you're in a psychiatric unit, you're much more likely to see a major depressive disorder or a bipolar disorder or schizophrenia condition or a schizophrenia spectrum disorder, other than, for example, obsessive compulsive disorder or a complication from substance abuse. So it's important to be aware of how prevalent conditions are in your setting. Another item in this is the features of the common conditions. For example, it's important to know how much other conditions occur in a diagnosis like schizophrenia. Why that is important is, for example, do schizophrenia patients have issues with sleep disturbance? Do schizophrenia patients have issues with irritability? Do schizophrenia patients have issues with mood? Why? Because if you don't know that you can actually see a patient with irritability or with insomnia, or with you may think, oh, maybe this is schizoaffective disorder, or maybe this is bipolar disorder. Same thing with major depression, for example. It's extremely important to scrutinize other features of illness. Each of the common conditions is very heterogeneous. That means that a major depressive disorder can present in few ways. It doesn't present in only one way. And being comfortable sort of appreciating the different nuances of each condition is important, because that helps you stay focused on the main condition and not misdiagnose. Number 4 is to think inside the DSM-5 box. That means that you have to really go by the criteria, and you will see that it's important to exclude substance use, exclude medical conditions. So this is, for example, you're eliciting depressed mood, anhedonia, insomnia, poor energy, and all that, but this is not hypothyroidism, for example. So this is extremely important. When you think inside the DSM-5 box and you document, you see something very good, which is your HMP looks like your mental status exam. This is a very good sign that you've done a good interview. Now, the last point is that inattention and applying this clinical method, so this is called the clinical method, right? Like just like the medical method, it will set you back and it will complicate treatment course. So it's important to be patient and to be skeptical. This is the kind of thing where you all hear about a doctor in private practice who sees X amount of patients, 25 in a night or 50 in a night. That can't be. It's just impossible. That means that you're not following the medical method. And here, it's the same thing in psychiatry. If you're not following the psychiatric interview, the way it's structured, it's impossible for you to come up with a good treatment plan that covers all that needs to be covered. Now, writing helps thinking. So when you're writing your HMP, you should structure your thoughts around the following questions. First, well, what are the demographics? How old is this person? Are they married? Where do they live? Are they housed? That kind of thing. And what past history do they have? This is a 34-year-old married woman with a history of major depressive disorder. So it's very good to start right out with that. The second, where there's a lot of high yield, is what is the pathway to the hospital? How did the patient come to the hospital? Tells you a lot of clues. For example, if they were brought by their family, that tells you that they have support. Were they picked up by the police? Did they come from jail? That starts you off thinking and about many of the biopsychosocial factors. Not only that, it also gives you clues to the diagnosis, because once you ask the patient, well, how did you come to the hospital? How did you end up coming here? You're able to see if they are having symptoms of psychosis, if they're having a cognitive impairment, and all that. Number 3, I think, is the most important item in this slide, is what is the likely diagnosis? So you will see that with experience, you switch from doing a checklist of questions. That is, if I teach you psychiatry, I would say, well, here are some of the questions you need to ask. And you'll see that you'll have to ask about mood, about sleep, about energy, about perception, about all these items that you ask about. But if you ask everything by a checklist, what we call a fishing expedition, it can confuse you and it can really make it very hard for you. As a psychiatrist, your main tool is your mental status exam and your feeling. What are your senses telling you? What are you seeing? So it's important to sort of have a hypothesis. You see a patient who looks extremely slowed and sad and crying, and that, so automatically you're thinking about major depressive disorder. And it's good to really make that point that, okay, I have to follow the mental status exam. So this is important. Related to number 3 is that each common psychiatric condition has a pertinent negative. So for example, if you're seeing someone presenting to you with depression, you want to make sure that you screen for mania, right? And if you're seeing someone who is presenting with psychosis, you really want to make sure that you've done a diligent workup for their medical condition and for any substance use and so forth. And then the last item is, if you can, and this is by no means the most important one, but it's extremely helpful if you can elicit it. What triggered the episode? A common item is for patients who are maintained on medications for a known condition is non-compliance with treatment. All right, this is a busy slide, but I would tell you it is extremely helpful to look at the biopsychosocial etiologic factors and weave them into your interview. So the biological factors are mostly four. Medical condition, is there a head injury? Is there complex partial seizures? Is there like a severe pain condition? Is there thyroid abnormality, which is very common, and you'll be asked about it in your board exam? Cardiac issue, cancers, drug interaction. So these are the medical issues. Another biological factor that is very common, and all the big government-funded studies tells you that patients don't take their medicines. They just don't, especially in conditions where there is psychosis or bipolar tendency. The third is substance intoxication. Alcohol is sort of the most abused substance, and it's very commonly used in patients who have comorbid psychiatric conditions. Is this an issue? You need to address it. And then family history. Again, we mentioned in the diagnosis, you really have to do a very thorough intake, and you have to follow the method. And you'll see, for example, that the only clue that your patient has bipolar disorder is that two of their relatives have bipolar mania, even though all you're eliciting is depression. So that is extremely important. Psychological factor, there are few of them, but the basic thing is to remember that trauma is a huge issue for a lot of the patients we see. Sometimes up to a third of our patients have history of abuse. This is not just for Western countries. This is actually true all over the world based on the WHO. And then the issue of burnout and persistent psychological stress, as you know, we open the news and we live ourselves a very stressful existence with wars, with natural disasters, with really having to just help people. And so having the stress response being on overdrive is just not a good thing. And if there's anything we can do to mitigate that, that tends to help. And then interpersonal issues like conflict or loss in significant relationship, apparent modes of psychological defenses, transference, countertransference, and then stress to the development stage. That means, if you remember from the Erickson psychodevelopmental stages, for example, if you have a patient who's in their 20s, mid-20s, you ask yourself, well, what is a patient in that age group should be doing? They should be in college, they should be starting employment, they should be maybe in a romantic relationship. And if they're not doing any of that, is that stressful? And you bet it is. Social factors, what is the living situation, employment, any of the support networks, and cultural factors. Now, this is sort of put in that way so that you would have something to go back to as you're treating the case. This really flows easier while you're doing the interview. Many of the questions that you're asking, according to the DSM-5, actually touch upon those and elicits that. But it's good to have these organized as etiologic factors, because you would see, for example, that they have bearing on response. Let me give you an example of a patient, maybe a 60-something-year-old man with severe depression, who you're treating with all sorts of medications, no response, and then you're treating with ECT, and there is modest response. But this is a patient who has spina bifida as a child, had a very complicated childhood, and had problems with bowel continence and bladder continence, and ended up being highly dependent on his mother. His mother sort of became his main caretaker as he was growing up as a child and dealing with these things. He grows up, he does okay, goes to college, has a job, and then he is married to a lady who more or less substitutes what his mom was doing. So then she becomes this highly supportive figure, and he's dependent on her. So this is someone who has dependent personality disorder. The patient comes to you as an aging person in their 60s with an unresponsive depression because their wife is divorcing them. So that significant person who they were dependent on has created that source of stress. So if you don't address this and you focus mostly on treating with the medications and with the electroconvulsive therapy, then you're neglecting a huge psychological factor in your biopsychosocial etiologic factor. So that's the point of really making sure that you're extremely diligent about keeping an eye on those factors. And this is sort of when you're documenting your assessment and plan, it's really good to weave it along the lines of the biopsychosocial etiologic factors. So a biological factor would be, this is a patient with bipolar mania who has not been taking their lithium for the past 3 months. That would be a biological factor. The patient is also dealing with the loss of their mother, who was a significant figure in their life and was encouraging them to take the lithium. That would be a psychological factor, loss. The patient has been employed and due to the symptoms of mania was suspended from work, would be social factor. So these are important factors to write in the assessment and plan, and it really helps you think about how to help the patient. All right, let me give you, we spoke a lot about the diagnosis, which is, you remember there were 5 guideposts, we spoke about the diagnosis. Let me give you a case where this is relevant. So this is a 36-year-old patient who's admitted with agitation, auditory hallucinations, irritability, loud, rambling speech, insomnia, paranoid delusions, and threatening to attack staff, right? So there's like agitation and there is psychosis. And patient was diagnosed as schizoaffective disorder, bipolar type, started on olanzapine 10 milligram twice a day, and divalproex 2,000 milligram. That's reasonable based on what you're hearing. 3 weeks though into the stay, the patient was mostly in bed, sad and not engaging in treatment. 5 weeks into the stay, the patient was eventually started on antidepressant, bupropion, and was started at half the dose and then up. 7 weeks into the stay, the patient continued to be lethargic and withdrawn. So the psychiatrist decides to wean off the divalproex. It's not irritable or agitated anymore, so they stop that. And then once the divalproex was stopped, the patient was discharged 10 days on just olanzapine and bupropion. So this is sort of where you started off diagnosing with schizoaffective disorder, bipolar type. You neglected these associated features of irritability, the rambling speech, the threats. These are still consistent with just schizophrenia. You don't need to diagnose schizoaffective disorder, bipolar type. That's a very exacting diagnosis with very exacting requirements. You have to have 2 weeks of just psychosis irrespective of the mood state, and you have to have a mood state that meets the full criteria for either a mania or a depressive episode. So this is when you start off diagnosing something that is not there. The cost for that down the road is several weeks of treating the wrong thing. All right. The next in the treatment guidepost is treatment. So let's talk about pharmacotherapy. There are practice guidelines or any evidence-based resource you choose to initiate treatment. The effectiveness sort of indicators are fast response for most of the pharmacologic agents. It's fast response is what tells you if this is going to be a good agent or not. Family history is very important. If someone's sister is preferentially responsive to sertraline, I might choose that if my patient is presenting also with depression. Neurobiological hypothesis, like what is your idea? What are you thinking you're going to do? So if you have someone who's presenting with low energy and impaired concentration, some resources suggest that maybe you should start with an antidepressant that has also norepinephrine moiety, sure. And then the severity of illness, that might tell you, for example, about the choice of the medicine. If we think, for example, about major depression, again, are there differences in terms of severity? Would you still choose, for example, an SSRI, or would that make you choose, for example, a tricyclic antidepressant? Proper dosing is a huge deal in the sense that you are at risk of underdosing or overdosing, but underdosing is more important in the beginning. It's sometimes psychiatrists or physicians are too cautious, and that's not necessarily a good thing. And then defining the target symptoms and measuring them. So what are you actually treating? If you split the conditions by their criteria, not everything is responsive, right? So you just have to see, well, what is responsive? Typically, for example, in a common condition like major depression, the neurovegetative signs respond pretty early on, and sleep, appetite, energy tend to normalize before even the mood. So that's important. And then you have to do careful initial monitoring of both the response and the side effect. If you're in the hospital, you can do that shift by shift, or in close outpatient follow-up. Fifth is using adjunctive meds that are appropriate for the condition. What that means is that if you, okay, well, I'm treating depression, but depression comes with anxiety and distress, with insomnia, it's really a good idea to give something sort of selective for the sleep or for the anxiety early on, especially in the first 2 weeks of treatment. Many times you don't do that, and you would prescribe a dose of an SSRI, and you just wait, and that retards the response tremendously. And then addressing comorbid condition, if you have a patient with a pain condition, they're complaining of their arthritis, and you're really not careful to make sure that they're taking an NSAID or acetaminophen, and you'll see that actually that affects the response to your treatment. Let me give you an example, a clinical example from a case that typifies this issue with treatment selection. You have a 64-year-old man with Lewy body dementia, and also a history of bipolar disorder. I haven't put that there, but bipolar disorder mostly. Presenting with anxiety, agitation, indecisiveness, insomnia, sad mood, and suicidal ideation. The patient was previously stable on a combination of lamotrigine and lithium. Now, due to Lewy body dementia, the patient is unable to tolerate antipsychotics. So we need, ECT was recommended, and the patient has to go off of the lamotrigine and the lithium. The patient was unable to consent due to indecision and rumination. So when you talk to him, it's just like completely ambivalent, completely indecisive, just extremely difficult to get him to do anything. So while you stop the lamotrigine and the lithium, you can think of, well, what would I give this person while they're awaiting getting the ECT? What ended up happening is the patient was prescribed lorazepam, just 1 milligram twice a day. And that just took care of the indecision and the rumination, and he was able to consent for ECT. He did extremely well after 12 sessions, and at the end, the lamotrigine and the lithium were resumed. So these are some of the issues that come in clinical care when you're thinking of treatment selection. There is just nothing to give this person. You can't give him an SSRI because he'll become manic. You can't give him sort of one of the evidence-based treatments for bipolar disorder that are antipsychotic based, whether it's olanzapine or whether it's even quetiapine or lorazepam. All these cause just extreme extrapyramidal side effects because of the Lewy body dementia. And here you see, with only lorazepam, you manage to get the patient much better. For psychotherapy in the inpatient setting, I don't want to belabor the point here, but In the inpatient setting, when you're in the hospital, you are doing a lot of psychotherapy. The most specific modality here is supportive psychotherapy. So it has psychodynamic principles. It's what we call a real doctor-patient relationship. So this concept just means that you're making yourself available in a way that you don't in sort of traditional psychotherapy. You're cultivating a relationship that is warm and sort of mutually respectful. Transference is not something you work with in a supportive relationship. You actually try and bolster defenses and soften them just to preserve self-esteem and ego function. Supportive psychotherapy uses CBT, dialectical behavioral therapy, motivational interviewing. So it's quite elastic. It can really use all those. And then the issues that the patient really needs to confront are not avoided, but they are sort of deferred because you want to get them to a place where they're able to be psychologically stronger to address them. So this is the concept of striking when the iron is cold. It's very different. The common things, you probably do this all the time. You give direct advice, you give encouragement, you give praise. Sometimes you talk about yourself or your family. And you do psychoeducation, you teach about the condition. So this is actually very useful psychotherapy, and it has its place. So now, it didn't used to be, but now it's one of the, what we call a core competency for residents. We make sure that they read about it and know about it and use it, and they're tested on it for their graduation. All right, third item, hope you guys are doing okay, is this is, I think, is extremely useful. This is when you have a patient that's just, there is treatment non-progression. They're not getting better. There's a partial or slow or no response whatsoever. So where would you look? Let's say I would ask Yasir about a case that I'm struggling with. The diagnosis is correct, the prognosis is correct. There's no issues with those two. The treatment selection was also good. So where would the Yasir look? He would more or less look at these 4 areas, which I call the 4 Ps. Poor compliance is sort of number 1. Most of the time, your patient is actually not taking the medicine. This, in psychiatry, this is really, really well documented and well known. Most of the clinicians here who are experienced and who have worked for years tell you that this is the case. The patients are not responding because the number 1 reason is that they're not taking the medicine. The second item is that there's something about the medicine itself. So pharmacology. Pharmacology is a big subject. And as a psychiatrist, it's extremely important that you're very comfortable with issues of pharmacodynamics, with pharmacokinetics, and that you understand basic pharmacology and that you understand the classes of the medications that you're using. This goes a long way, and you will see that the more you know about the pharmacology of the medication, the better it is for you, because this is such a central modality of treatment that we use. Psychopathology. If I give you the 3 common conditions, the major depression, bipolar mania, and schizophrenia, knowing these conditions really well, being experienced with them, and knowing the different varieties of presentations is very, very, very helpful. So it's really important that you don't avoid seeing patients. It's important that you spend the time to see more patients, to even take more chances early on, especially when you're young and healthy, not old like me. But it's extremely important to do that early on to get to know the illness. Many times when you develop expertise, so now you're an expert, I guess you're an expert psychiatrist. Expertise doesn't mean that you know everything. It just simply means that you know what you know. So you know a schizophrenia case very well. That is extremely important because many times you may not know what the other condition is, but you know for a fact that it's not schizophrenia. So it's important to know that. And then the psychosocial factors are really important. It's a huge area. So what is it about the patient and their environment right? How can you know that unless you really understand the biopsychosocial etiologic factors and that you've really invested in them? So let me give you examples. Poor adherence, we do in our unit this thing called cheeking precaution. So when you put the pill or the tablet or the liquid on the patient's mouth, you ask them to open their mouth, to elevate their tongue, to talk to you, right? So that we do that routinely for all patients because you have no idea how crafty the patients are. Some patients put the pill in their beard. Some patients put them in a loose tooth and they go spit it out. It's a real thing. So you should, the advice really is never underestimate its occurrence. And then in pharmacology, issues of dosing, many times, and Yasser and Azadin will tell you here in the US, you get a consultation from a primary care physician who's treating someone with depression and said, well, the patient is not responding. Okay, what are you prescribing? Sertraline. How much? 25 milligrams. Okay, go up to 100 over the next 2 weeks. And so dosing is very common issue. Pharmacokinetics is, are they taking another medication that is causing an interaction? Do they have a health condition that interferes with it? Are you treating someone with, let's say, an antipsychotic, but they have dialysis? Are you aware of that? Are you aware of what's happening? And then pharmacodynamics. You have a treatment-resistant patient and you're prescribing 4 milligrams of risperidone. But this is a patient who historically responded to 8 milligrams of risperidone. You don't prescribe it that high dose. But this particular patient have receptors that are extremely insensitive, and they have what is described in Essential Psychopharmacology textbook by Stephen Stahl as pharmacodynamic failure. So that means that their receptors, for one reason or the other, are just not that sensitive. But when you get them to a certain dose, they show a response. This is typical in chronic schizophrenics who are institutionalized. They tend to respond to higher doses. So then psychopathology, and this is a very near and dear condition to Yasser's heart. Catatonia is often very hard to detect, and it's very common in inpatient settings. So it's really important to make sure that you're diagnosing it and that you're familiar with its different varieties and that you're using the Bush-Francis scale to elicit it. And the same thing with psychosis and covert substance abuse. A lot of patients end up getting marijuana inside the hospital or other issues. Now with psychosocial, there is housing, work. We have this family leave that we can offer families so they can take the time and help the patient. Also isolation. We see that with a lot of elderly patients who and their kids are scattered all over and they're alone, and so we have to address that. So these are sort of examples for those 4 items that we look at when the patient is not responding. Now, treatment resistance. Once you have evidence of repeated poor response, less than 25% to at least 2 previous medications trials, you really have to get diligent history and really see how the patient responds so you can actually arrive at, well, this is a treatment-resistant condition early on. The last thing to remember is that there's a lot of attitudinal barriers on the part of the psychiatrists themselves to implementing evidence-based choices for this clinical presentation. For example, to ECT. I don't remember, I haven't practiced in Sudan for many years, and when I practice for a very little time, but I don't remember there's a huge barrier to ECT. Actually, it was readily available in Tijani Mahi or in other hospitals. But here in the United States, for example, it's a huge to-do. People just freak out when you tell them about ECT. And I'm not talking about the patient, I'm talking about the psychiatrist. They just don't like, they perceive it as logistically challenging, as a hassle, as insurance barriers, and so forth. Same thing with clozapine, which really can offer a huge differential in terms of efficacy for patients with resistant schizophrenia. They just don't like to do the lab work and all that. So this is important to know. The last guidepost is prognosis. So again, I'm consulting with Yasser and about a case, but it seems like I don't understand the prognosis of the case, and Yasser is looking at this. Now, when you attend to the clinical guideposts, it's true that remission and recovery is realistic for a lot of the cases that we treat. And then treatment resistance and known prognosis factor, however, can deadlock further recovery efforts. So it's important to define any treatment alternatives when they're available, but it's important to identify the risks of aggressive or prolonged treatment. It can be very harmful for the patient. And it's important to involve the family and manage their expectations, but it's also important to do your due diligence in empathizing, in grieving with the patients, and in resolving the issue of treatment. So I'll give you an example. This might be a case that I would present to Yasser or Azzuddin and say, I have this 70-year-old lady who has a history of bipolar disorder. She does. Long history of response to medications. And she develops normal pressure hydrocephalus, and neurocognitive disorder become prominent. So she becomes demented. As psychiatrists, you will see in your career that patients with history of mood disorders, for example, or history of psychosis, what happens to them when they grow old? Now, when all of us hit 65 years of age, our risk of dementia goes up, and then it doubles every 5 years. That's in the general population. So then the prevalence at the old one, if you make it to 85, is like almost a third of 1 out of 3 people have Alzheimer's disease. So it becomes very prevalent. Now, this patient is 70 years old. So in the general population of patients who are her age, they're at the risk of having dementia of around 8% or so, or 16%. For patients who has a history of repeated mood episodes, that risk is almost double. So it's almost like 30-something% that you would be at risk of developing dementia. So the children were very educated, very aggressive. They wanted treatment, and they were not receptive to any education or treatment plan, and persuaded the psychiatrist to do ECT because the patient couldn't really tolerate any of the medications that she used to tolerate. And with the ECT, after only a few treatments, what became apparent is that the patient is becoming much more delirious. So it's very dangerous to treat. Once they saw that, it was easier to sort of speak to them about what is happening, that the prognosis is not good with treatment with bipolar disorder medications or with ECT. So that saves you time and really helps you, but you have to do it in a way that is respectful, in a way that takes into account that for these children of the patient, they're thinking of their mother, and they're thinking of the past response. So meeting them and being on the same wavelength and explaining what happens as people age is extremely important. Okay, now the rest of this is really just applying those principles to some of the common clinical conditions. For most inpatient units, patients who stay for a month or longer typically have these 3 conditions. They can have personality disorders, anxiety disorders, substance-related disorder, but for most of the time, the overwhelming majority, in my experience, just as an administrator, looking at the numbers and looking at those diagnostic groups, it's mostly the top 3 conditions that you see patients staying for an extended time in the hospital. So let me give you an example really fast, because I want to give you time to ask questions. If we talk about the psychotic disorders, I'm not going to go over the criteria for schizophrenia. It's known. It's not the point of the presentation. And then response, we mentioned about using measurable clinical indicators, a team assessment, so really asking the other clinicians. And then treating agitation early on is helpful. This is sort of, if you're going to be running a hospital unit, or you're going to have a hospital that you want to add a psychiatric wing to it, it's really true that harmony among the staff, so a good working climate. You have a team that is more or less cohesive, and they like each other and they look after each other, seems to be the most important item in preventing aggression in the psychiatric unit. It's not really having more nurses or having male nurses or having security or any of that. So this is important, and this is sort of a tangential point, but it really does flow into offering quality treatment. So many times the main task of an administrator is just to recruit good people who know what they're doing and have very good interpersonal skills. All right, let me skip all those. A little bit about the medication. So this is like we mentioned about treatment selections for schizophrenia. It's usually now it's atypical antipsychotics. You really do select based on the past history, side effect profile, cost, and then you want to prevent movement abnormalities. Weight gain and metabolic syndrome are the major challenges. So here there is this excellent sort of meta-analysis by Louai. This appeared in the Lancet in 2013. This is called a multiple treatment meta-analysis. What that means is that this is really looking at the actual clinical trials that were published and doing a meta-analysis of those clinical trials. So this is not real world necessarily, but it's also very good to know. And it compared antipsychotics and placebo. The primary outcome was just mean overall reduction in symptoms, and then there was all-cause discontinuation, weight gain, extrapyramidal side effects. So all these side effects, they were examined. Sedation, QTC, included a lot of trials, over 200 with over 40,000 patients. So the antipsychotics differ substantially in their side effect, but there was small differences in efficacy. So you would see here they're doing this ranking of the antipsychotics, and if you look at the direction of sort of the means, where to the left, it really favors the active drug, and nobody is surprised clozapine ranks highest. After that, you will see amisulpride, which we don't have here in the US. I know it's in Europe. And then olanzapine and risperidone and so forth. The rest is not really huge differences. But this just tells you that if you're using clozapine, olanzapine, risperidone, haloperidol, which are in very common inpatient use, then you're on the right track. This was a big government-funded studies called Clinical Antipsychotic Trial of Intervention Effectiveness. This goes back to sort of when you look at the 4 areas for non-response, non-compliance, they were not looking for non-compliance, they were looking for differences in efficacy and side effects. And they found out that their main outcome was that after 6 months, close to 70, like 3/4 of the patients were not taking the medicine. So that was a huge finding. The tolerability was comparable among the side effects. They used some of the commonest atypical antipsychotics and one of the medium potency typical antipsychotics, perfenazine, and they were all more or less the same. Olanzapine may have had a small advantage, but it caused a whole lot of side effects, especially weight gain. So speed of response, does it matter? Just teach you, I think this is probably true for all of psychopharmacology. If you have 25% reduction in symptoms in the first 2 weeks, not achieved, the response is likely to be low after a month. So that means you shouldn't be like just changing medications helter-skelter, but it just tells you that the response is sort of cumulative. Once you start an antipsychotic, for example, you should be seeing some response. If you're not, and if you're not even seeing like 25 response after 2 weeks, it's really, and you're sure that the patient has taken the medicine, you can switch earlier. So that's really the point of mentioning this. And then more improvement actually occurs early on. So in the first 2 weeks than in the next 2 weeks. And then so far, risperidone, olanzapine, and the conventional antipsychotics may work a little bit faster. This is not very robust research, but it's there. Same principle, looking at compliance and making sure that you address it. There are few formulations for medications that you can use. You can use the injectables. Those work to ward off compliance. Then in terms of pharmacology, you're looking at correct dosing for antipsychotics. That's very important. We did mention a little bit about the pharmacodynamic failure and pharmacokinetic failure. And then drug interactions, if you're prescribing Tegretol with haloperidol, the Tegretol is an inducer. It will start to eat up your Haldol, and you see patients developing like symptoms. And then there are two medications that have credible blood levels, and those are haloperidol and clozapine. And then it's really good to start lorazepam early on when the patient is agitated and not sleeping. In terms of psychopathology, it's really good to look at mood symptoms in schizophrenia and OCD symptoms and address those. It's important to do risk assessments. Patients sometimes are demoralized, especially in post-psychotic depression. They want to hurt themselves, and that's why they're not improving. Catatonia also is very stubborn and can hide itself. If you're allowing the patient visitors, are they giving them something? Are they giving them marijuana? Are they giving them any other substances? Medical mimics, I don't know if you guys read the book Brain on Fire or heard about anti-NMDA encephalitis. That's now very well established, especially for early onset psychosis in a young person. It's extremely important to make sure that you're not missing reversible cause. And then using measurement scales and knowing the natural history of the condition and the prognosis. With psychosocial issues, you really have to restore self-esteem, hope, morale. You should help with housing if needed. You should empower families. We have the National Alliance for the Mentally Ill. And then really any resources that you can have a social worker sort of help the patient with. When it comes to treatment resistance, you have to consider clozapine or ECT. If those two are not available, then combination antipsychotics or adjunctive agents. Unfortunately, combination antipsychotics and adjunctive agents are not going to get you very far. So if you can find clozapine, it's a good choice. And if you have ECT, it might help. We talked about the clinician perception and attitude. That's the biggest obstacle actually to prescribing clozapine in Western countries. And these are sort of some of the... this is sort of an example of using that model, using the guidepost to sort of look at the case and go back to these important items of diagnosis, treatment selection, non-response, and really prognosis. So these are sort of important, and they would actually make the case that you're treating extremely rich, because you can use one case and use these guideposts to enlarge your knowledge base. So I can do bipolar mania and I can do depression, but I think you get the idea. Yasir, do you want us to stop and sort of see if folks have questions, or should I go on?
I think you can take a few minutes, 1 or 2 minutes.
Okay. So I'll stop here and see, does anyone have any thoughts or anything they want to share? Anything you'd like me to clarify or answer for you?
until people come with questions. في question كان في الشات هنا. is the neurocognitive disorder considered to be a common prognosis in bipolar cases with advanced age?
Very good question. So that depends on the number of episodes. It correlates with the total number of lifetime episodes. The more lifetime episodes of mood symptoms in bipolar disorder, the more is the risk for development of a neurocognitive disorder. But let's say you had one mania in your life. Does that put you in a high risk for neurocognitive disorder? It doesn't. So the number of episodes. Great question. All right. You might have more questions. An overall time come, yes. Is it 1 hour or
1 hour plus or minus?
Plus or minus. Okay. So instead of me sort of going over mania and depression, because the principle is the same, we're going to use the guideposts for each case, and that might take more time. Let me see here if I have cases. Okay. For example, in mania, we had that multiple treatment meta-analysis for schizophrenia by Stefan Louai. And here for mania medication, so anti-manic agents, there was a similar multiple treatment meta-analysis by Andrea Cipriani that appeared in the Lancet in 2011. And you can see if you go from left to right, the one that has 23 over it, this is placebo. I like to show this slide for my colleagues who use lamotrigine for mania or who use gabapentin for mania, because in this meta-analysis, they did worse than placebo. So that's really important to know. You're treating mania here. But you can see that all the way to the left, risperidone seems to be a really good anti-manic in terms of acceptability and efficacy, and olanzapine and haloperidol as well. What was surprising to me is that they're so much better tolerated than lithium and valproate in mania. So I did not expect that. And then this is also now a classic picture in psychopharmacology. If you like psychopharmacology, you probably have seen this somewhere. And it looks like sort of the sun and the sky in the back. But all the way up is those that are highly efficacious, those who are all the way to the right. So high and to the right means sort of more acceptable and more efficacious. So you see risperidone is quite acceptable to the patients and quite efficacious for mania, while haloperidol, while it's really effective as well, see, it's very high, but it's not as tolerable, and that's true. You get the extrapyramidal side effects with it. And then you look like to an agent all the way in the bottom left corner, gabapentin. It's pretty acceptable, right? but it's not efficacious. It's extremely low in its ranking when it comes to efficacy. So this is a nice slide to have. Now, for bipolar mania treatment, antipsychotic monotherapy is likely okay. So really good to use benzodiazepines early in treatment. A lot of people don't use divalproex ER for mania. It's pretty good, and you can dose it right off the bat at the dose that you want. So you can use 1,500 or 2,000 right off the bat. The last point is renal issues shouldn't rule out lithium, and I think those who practiced clinical psychiatry for a long time know that it's extremely hard to find alternatives to lithium when someone had used it for decades and were stable on it, and then they developed renal failure. study that I'm quoting here just tells you that this may not be necessary, that in consultation with a nephrologist, you can actually safely re-challenge with lithium in a large majority of cases. So many times in the inpatient setting, that's what we end up doing. We have a patient whose clinician really tried very hard with divalproex, with combination antipsychotics to restore them to euthymia, and it's just impossible. And we consult the nephrologist to go over the creatinine, we go over the BUN, we go over the ultrasound of the kidney, and the nephrologist say, you know, go ahead and start the lithium. I'll help you monitor it. So that's important to know. Yeah, so we mentioned that already. Now, prescribing with the end in mind, let's say someone asks you, if you were to choose one antipsychotic and one mood stabilizer, that's it. This is a universe where no other alternatives exist. What are you going to choose? There is no correct answer, by the way, but if you said, well, I'll choose olanzapine and I'll choose lithium, then that just means that you really have a good idea of what works for maintenance, and that your life would be much easier if you chose something else. So this is not going to help all the patients with bipolar illness, but it's probably the best choice, is to have those two under your armamentarium. So here, what I'm trying to show you is that it really matters for maintenance what the patient is presenting with. Is it mania? Is it depression? Or is it both? And that the best data based on what's FDA approved and what the literature says, lithium seems to be quite effective for mania. Not the best anti-manic, but it's fine. It's really better for depression, and it's better for maintenance for both depression and mania. Olanzapine is the same way. It can help you when you have bipolar depression. It can help you when you have bipolar mania. And it's a decent maintenance agent as well. Okay, the rest, so non-compliance is the same in terms of pharmacology. One thing is that if you're having poor response, so if I'm consulting with someone, they might say, well, what else is the patient on? And they say, well, they're taking trazodone for sleep. Sometimes that's a big thing. So, well, why don't you try stopping trazodone? No, that stops the mania. So psychopathology, catatonia or excited catatonia can be present, and benzodiazepines can help with that. One of the biggest medical conditions in bipolar disorder is thyroid abnormalities, because if you have unstable thyroid function, it really makes the patient rapid cycling. It really leads to poor response to the medications, and rectifying that can be a good first step. Now, for the psychosocial for mania, one of the big things is addressing the things that are lost to the mania. So a lot of the patients just keep going on because they think they really can gain something in their grandiosity and in their lack of insight. But when you address that, that can really be helpful. So with mania, if you have rapid cycling, it's sort of the equivalent of treatment resistance. And clozapine is underused here, but it can actually help, and ECT can actually help. Combination mood stabilizers are actually better than combination antipsychotics for schizophrenia. So if you do by divalproex and lithium for rapid cycling, it tends to work better. Let me skip that. Now for major depression, this is the same principle essentially. Let me see if there's a question here. Well, thank you. For major depression, I'm not going to belabor the same thing. I think you get the idea what we're going to be looking for, but some of the medications we use. This is a very famous study called Sequence Treatment Alternatives to Relieve Depression. It's a large government-funded study that looked at, well, how how many patients can you get to remission if you treat sequentially? If you start with an SSRI that is in common practice, at that time it was citalopram. In real practice, what happens? People either switch or they would augment, right? So what happens in that setting? And then after that, people just change it all up, and then they leave the SSRIs altogether and they go to drugs like mirtazapine or nortriptyline, which is a tricyclic, or they will augment with lithium or with thyroid, right? And then the last thing, they'll just reach out for older medications like the monoamine oxidase inhibitors. And then or they would combine mirtazapine with venlafaxine. So what happens in each sequence? In the beginning, you get about a third patient getting to remission with just one treatment, like citalopram. And then the rate of remission goes up by very small increment in each stage. So there was good news and bad news. The good news was that you actually can get about 3/4 of your patient to remission with 4 sequential treatments. But the bad news was that you actually might need 4 sequences of treatment. And so it was a very important and a milestone study, but it sort of supported what clinicians have been doing. There's just no big differences between your strategies. You'll have to keep trying and get patients to remission, so not to give up. Again, there was these, I think with this presentation, I'm going to get you hooked on multiple treatment meta-analyses. Look at them. They don't appear, they're very rare. They appear every few years. There was one, again, that was published by The Lancet by this Italian group, Cipriani and colleagues, and they just essentially looked at the clinical trials for a whole lot of common antidepressants with 25,000 patients. And the finding really supported what we're using. So as citalopram, venlafaxine, mirtazapine, and sertraline, these are very commonly used medications, at least here in the US. And sertraline ranked the top for balancing benefit, acceptability, and cost. And I think it's a favorite of a lot of clinicians. So all this is saying is that it's justifying the practice that we already have. One important thing when you're using response, believe it or not, this is established for major depression in particular, using the PHQ-9, the Hamilton, the Beck, Montgomery-Asberg, this is depression scale, is much better than your clinical impression. This is just very well established. And a big reason for that is that a lot of these scales measure better the neurovegetative signs, which respond earlier to treatment. So the bottom line is, if you have them, use them. Even if you use something as simple to use as the clinical global impression scale, much better than not using it. Okay, and then ruling out suicidal intent as a reason for non-compliance is important in depression. So there are patients who are terminally suicidal and their intent prevents them from responding. Let me see here. Yeah, treatment resistance. So there are predictors of treatment resistance in major depression. If you have higher baseline severity and longer duration of illness, that's not a good sign. If you have early onset of the illness, if you have a whole lot of anxiety and panic symptoms and substance abuse, if you have history of childhood abuse and there are no social supports, that can usher treatment resistance. What would you treat with? There are some antipsychotics. So for the STAR-D, essentially says don't quit, just keep going, because after 4 trials, the rate of remission goes up. So keep going. Don't give up on treating. And then you can augment. We know that aripiprazole and now brexpiprazole, which is its cousin essentially, are FDA approved for augmentation, but that doesn't mean that the other atypical antipsychotics don't work. You could easily add quetiapine or risperidone. I think it will do the same thing. And then ECT. Now, ECT is helpful with psychosis, with catatonia, with melancholic features, when you have a patient that is failing to thrive, so they're anorexic, they're not eating, they're allergic, they're in bed, persistent suicidality. And if you delay referral, you may limit its effectiveness. ECT image, again, I'm not sure how this is received in Sudan. Here, believe it or not, very advanced, even if you think of California, one of the most advanced states, they do all the tech industry, and that they have an extremely backward notion of ECT. And this picture is from this famous movie called One Flew Over the Cuckoo's Nest. And this is Jack Nicholson. That's in the 70s when he was younger. He was sort of a bit of a rebel and was incarcerated in this psychiatric hospital, and they tried to subdue him. One of the ways they did that was by using ECT. I'm not playing the image, but the video, but in the video, you can actually look it on YouTube. Jack Nicholson, One Flew Over the Cuckoo's Nest, ECT scene. It's extremely upsetting because he's awake, and they subdue him like that. So you see many few men there who are gonna actually strap him down, and they're gonna actually do ECT on him while he's awake. So that's what a lot of people in the US in the 70s saw, and that's their image of ECT, and it sort of became entrenched in the collective psyche of America. And so I remember that because whenever I'm talking to a patient about ECT, I remember consent, indication, method, and meaning. So consent meaning that, you know, this is a procedure that you have to say yes. You have to say, I want to have this. The state regulates this very carefully. And for those who can't consent, you have to obtain a court order. So I reassure the patient, this is completely with your consent, and at any time, if you don't want to do it, we'll stop it. Number two is indication. ECT is not for all psychiatric presentations. It's mostly for depression, and for depression that has catatonic features, psychotic features, a lot of anxious distress, and that kind of thing. It's also very good for rapid cycling, for treatment-resistant psychosis. So it has set indications. And then with the method, what a lot of people don't know is that I think in Sudan they were doing like unmodified ECT, which means there is no muscle blockade, muscle relaxant, or general anesthesia. In some places in Sudan, I think they do that, but for in the most of the general psychiatric wards, they only use Valium. But when it comes to the method and when it comes to practice of ECT in the States, you're asleep. You're given a short-acting anesthetic and you're given a muscle relaxant. So you're not there to witness the treatment, and you're not actually experiencing a motor seizure because you're under muscle relaxants. You're not flailing and jumping in place like a lot of people imagine. And then the meaning of it, I always speak of it as the facts are in terms of the literature. It's the top-ranking antidepressant. It really is, and there's just no way around it. It's a very effective antidepressant, and that's really what it means. You're getting a treatment. And then I also just try and impress upon patients that you're taking antidepressants. Those work on the chemistry of the brain, and the chemistry of the brain ultimately affects the electrical activity of the brain. Here, you're really just going straight to the electrical activity of the brain. So not the most sort of reality-based conversation, but it's not either far off either. It's pretty persuasive for the patients. So I'll end with this, and this won't go to the other condition, but let me summarize. Yeah. Careful history taking following the standard diagnostic criteria is essential. So this is really what they say. If you put garbage in, you'll get garbage out. So don't do that. Make sure that you spend the time. This is sort of the most important investment of time that you will have. So you will have to do a very good intake, a very good psychiatric interview that is very diagnostic driven. And then number two, selecting evidence-based medication with the best benefit to risk ratio and administering them early is key to stabilizing acutely ill psychiatric patients. Number three is sort of what would you look for if the patient is not responding? You look at, is the patient actually taking the medication? We gave a lot of literature telling you that they actually don't take the medicine. Do you know the pharmacology of the medications that you're prescribing? Do you know the psychopathology of the common conditions that you're treating? And are you aware of this person? Do you know this patient and their environment, right? Do you know the psychosocial factors? And then are you identifying treatment resistance early on and applying evidence-based treatment, or are you just flying blind? Don't do that. If you have a patient with treatment resistance, you have to offer treatments that are evidence-based for treatment-resistant conditions. And then when it comes to prognosis, you have to define the end of inpatient treatment or the end of treatment. It's like, okay, the treatment hurts this patient. They've developed dementia already. So these are the things that I wanted to share with you. And I'll see if you guys have any questions.
شكرا جزيلا لؤي، المحاضرة قيمة وبعدينك يعني it's very rich، يعني a lot of information ل different topics وكلها يعني of need يعني لأي practitioners بالذات الناس الشغالة inpatient. أي زول عنده سؤال يعني they can go in ولا raise their hand ويسأل السؤال طوالي. شايف في lot of many thanks قاعدة في.
Yeah, you're welcome. والله it's mostly يعني what do they call it? Old wine in new bottles. It's really just a way to organize your thinking and to have a plan. One of the things that you see when a case is not responding, it's just a chance to really reiterate the basics. And as I mentioned, as an administrator, we always ask, well, where is the money, right? Why is this patient still here? Or why are they not responding? The answer is always these basic ingredients of care. So you take care of the basics, you'll take care of the patient and you'll do it efficiently.
دكتور أنا عندي تعليق ممكن. السلام عليكم.
عليكم السلام، تفضل طارق.
طبعا أنا من يعني الحاجات اللي كانت بتواجهنا في السودان وكده، يعني أنت دائما مثلا لو في سايكاتريست قبلك شاف الكيس أو كده، الدوكيومنتيشن لما يكون ذاته ممتاز أو أي سيمتوم حصلت أو أي حاجة دوكيومنتد it will save a lot of time حتى في يعني في النيو اسسمنت. فأنت دائما بتلقى إنه شنو، انت يو ادميت البيشنت وما بكون في مثلا بريفيس هيستوري كويس وبتاخد الهيستوري ديورنج الانبيشن يعني بتكتشف حاجات جديده، ودي بتؤدي انه مثلا في السودان دائما البيشنت بيقعدوا عندنا مرات يعني شهر شهرين اكثر حاجه، يعني بيقعدوا فتره طويله يعني. فدي الملاحظه الاساسيه، انه حتى في السيكاتري انا بشوف الرول اوف دوكيومنتيشن بتاع اي دكتور، الدوكيومنتيشن وكيبنج الريكوردز دي حاجه مهمه بتفيد حتى another psychiatrist لما يجي تو اساس البيشن يعني هسه مثلا زي ما انت كرمت المثال بتاع قلت ال 70 year old اللي عندها ديمنشيا دي، عندها جود ريكوردز بيكون موجود بتاع انه البايبور ادميني جاته كم ابيسود والديبريشن كم ابيسود وفي السنه دي كان كم ابيسود، بيكون في ريكوردز انا اكيد متاكد. لكن الحاجه دي في السودان طبعا يعني اصعب حاجه بتواجهنا. والهيستوري مرات حتى انت انفورمنت ما بتلقى انفورمنت يديك يعني من الفاميلي ولا من يعني في a lot of social يعني يسموها تحديات يعني. فدي بس يعني خاطر حبيت اشاركها معك. وبرضه يعني انا مثلا شخصيا انا طبعا ار 4 خلصت يعني تقريبا. انا من الحاجات اللي كانت تواجهني يعني كده او عندي فيها انترست لما الدبريشن البرزنتيشن بتاع الدبريشن. لما يعني انا شفتها مثلا بوست شيزوفرينيك ديبريشن، وشفت مثلا ديبريشن بتاع شيزوفرينيك، وديبريشن يونيبولر، وديبريشن باي بولر. الحاجات دي ما بتجي يعني الا بالبراكتس. فيا ريت تدينا عنها نقطه كده او كلينيكال يعني من واقع خبرتك كيف الناس تقدر تفرق بينها خاصه في السنين الاولى يعني. انه كيف يفرق. ايوه شكرا. شكرا واسف على الاطاله.
شكرا. لا ابدا، يعني عارف يا طارق، I agree 100%. طبعا الدوكيومنتيشن is very important. انت سالت كان يعني سؤال مهم جدا جدا. In the beginning you have depression, how would you get يعني the correct kind of diagnosis? If you don't have the records and you don't have collateral, what you develop over time is طبعا your clinical experience. In the beginning of the lecture I mentioned it's extremely important that you see a lot of cases, because then you develop your own sort of appreciation of the heterogeneity of each condition. So is this just major depressive disorder, or is this bipolar disorder? Are there associated features that would tell you, okay, this is just likely going to be just a major depressive disorder, or are there associated features that would tell you that this is a different kind? This is, for example, bipolar disorder. There is no substitute for good clinical interviewing. حتى الhistory. Yeah, many times one of the things that I like to do and tells you a lot for trainees, for my residents, these are mostly second year residents. They like to go read the chart first and then come interview the patient. So when it's my turn to be with them, I always tell them, I switch the patient. So they said, I'm going to be seeing this patient. I say, no, you're not. You're going to see this patient who you know nothing about. Now come and show me how you interview the patient without knowing anything about them. And then really trying to get a sense of their capacity to do the mental status exam. The mental status exam is a skill that develops over time. It's not just about description. It's really about being able to detect sort of nuances. For example, how much irritability is the kind of irritability you would see in a major depressive disorder? Or how much is this irritability an indication that this is bipolar mania? There is just no correct way of telling someone that unless they see it often and often again. So I would see the same patient, my resident would tell me this is depression. I'll tell them, I think this is bipolar mania. And how do I do that? Because I have seen that this degree of irritability is incompatible with the depressive episode. This degree of irritability, standing up and trying to actually get out of the room, is much more common in sort of bipolar mania. So because I have spent the time seeing a lot of patients and seeing a lot of cases, the error rate is lower. And that's just because I've been doing this for a long time, right? So my error rate is lower than the resident, but that doesn't mean that I get it right all the time. It's just because in this instance, in this specific example, my appreciation of the role of irritability in the presentation was more accurate based on my experience and based on seeing these cases. So another way of doing this is that which symptom is consistent with the DSM-5 criteria for a given condition and which symptom is not. And again, the irritability is a very good point. You expect to see a degree of irritability in depression, but you don't expect it to be pervasive, for example, right? Speech, for example. Is this pressured speech, or is this just a patient who's anxious and is talking a lot, trying to tell you things? So I'm interviewing a patient with a resident, and they tell me this is pressured speech because the patient is just telling them too much. But it takes time and experience to know what is the difference between an over-inclusive speech, someone who is anxious to tell you everything they think they need you to tell, and someone who has actually genuine pressured speech, right? So I would tell them, no, this is actually not pressured speech. This is just over-inclusive speech. The patient is anxious to tell you what they think you need to know, and they don't want you to miss anything. So the two things related to your question, Ya Tariq, are really making sure which symptom does not fit with the DSM-5 criteria, and really just continuing to see more cases. There is no substitute for that.
شكرا جزيلا دكتور.
يعطيك العافية.
يزن عندي سؤال ثاني؟ معناته لو ما في سؤال ثاني ممكن
خليني اقول يا ياسر
تفضل.
شكرا جزيلا. عايز اقول بس ثانك يو لدكتور لؤي for this great and informative lecture، وارجو انه يعني طلبتنا والترين بتاعنا يكون استفادوا منها كثير. شكرا يا لؤي.
شكرا جزيلا يا فتحي. My pleasure.
الله يبارك. الله يسلمك.
Thank you so much for your time and for your attention. And go and see patients. The best teacher is the patient on the case.